Okay, if everyone can start maybe quieting down a little, we are going to start today's seminar. My name is Naomi Inglar. I work for the Tulane Center of Excellence in Maternal and Child Health, as well as the Tulane Prevention Research Center, two of today's sponsors. We also want to thank our other sponsor for today, the Tulane Society for Young Black Public Health Professionals. This is part of our series called Health, Racism, and Communication Seminar Series. And this is our first for the semester, and we are very honored today to have Dr. Niyogi as well as Dr. Wennerstrom. And I will read their bios, but first some housekeeping. If you haven't signed in or taken an evaluation form, they're outside the door of the classroom. Oh, they're inside now. Please do sign in so we can send you information in follow-up to the seminar, as well as the evaluations help us know how we're doing. Are we meeting your needs? Are we meeting your expectations? Do you have any suggestions for future seminars? We are also recording this seminar, and the recording will be posted on YouTube. So again, if you give us your email address, we'll be able to send you that YouTube link. So, without further ado, our speakers, Dr. Anjali Niyogi is a clinical assistant professor of internal medicine and pediatrics at the Tulane School of Medicine. She is director of the formerly incarcerated transition clinic located at the Ruth Fertel Tulane Community Health Center. She is also co-director of the RIGHT program, which stands for Resident Initiative in Global Health at Tulane. And she is a hospitalist at University Hospital and teaches medical students and residents. As a member of the Physicians for Human Rights Asylum Network, Dr. Niyogi conducts evaluations for asylum seekers in Louisiana and the Gulf Coast. She is also an adjunct assistant professor in the Department of Tropical Medicine at the Tulane School of Public Health and Tropical Medicine. Dr. Ashley Wennerstrom is an assistant professor of medicine at the Tulane School of Medicine and director of the Louisiana Community Health Worker Institute. She's also a faculty co-investigator for the Tulane Prevention Research Center. Dr. Wennerstrom is a co-founder and past chair of the Louisiana Community Health Outreach Network, a local professional group for community health workers. Dr. Wennerstrom is also the Community Health Clerkship Director for the Tulane School of Medicine. She's also leading a project funded by the Patient-Centered Outcomes Research Institute, PCORI, that aims to address barriers that former prisoners face in accessing healthcare and support services. Also, I want to mention our format is a little different this semester. We're going to have an hour of seminar in this room, and then for anyone who wants to stay for additional Q&A and discussion, we will go to room 1202 for 30 minutes. So at 1 o'clock, we'll move into that room, and then we can have more intimate Q&A. So I would like you all to join me in welcoming our speakers today.
Can you hear me? Great. Thank you so much for having us here. So I'm going to just start off before we go into the slides and give you a very small, brief background about how I got started and interested in this, and Ashley will probably do the same. But I got interested in working with the formerly incarcerated through my work as a hospitalist at university. So I trained at Charity, which went on to university and is now University Medical Center. But the Charity system has always been the contract hospital for the Department of Corrections. So what that means is anytime you have someone who is currently incarcerated who requires hospitalization or services in this region, they come to the Charity hospital system. And so I've taken care of lots of prisoners who've come into the hospital over time. And then one day I had a medical student who asked a very astute question and said, well, what happens once they're released? Where do they go to get medical care? I didn't know the answer, and I started digging and went to Google, and Google didn't show up anything. And so I ended up then calling the medical director for the Department of Corrections and said, you know, what happens to these people? And turned out there was actually no protocol in place. Simultaneously, I was seeing a lot of people who had been formerly incarcerated showing up in the emergency rooms and the ICUs and getting admitted because they weren't able to get their follow-up care. And so that was sort of how this idea came to being, saying, you know, we really need to target this population that has been severely underserved. So today we'll just really quickly go over, we'll talk about the background and really the background about statistics with incarcerated populations in our region. We'll talk about, Ashley's going to talk a little bit about how we came about in designing the services that we provide at the FIT Clinic, and that was through interviewing people who were directly affected by this. And we'll talk a little bit more about how the FIT Clinic itself was developed and then where we are right now. All right. So as many of you probably are aware, that Louisiana has the highest incarceration rate in the country, and since the United States incarcerates most people in the world, at least documented people in the world, we have the highest incarceration rate in the world. Within Louisiana, New Orleans has the highest population of incarcerated. And so you can just read some of these statistics, but we have about 1.4% of the adult population in Louisiana is currently incarcerated. About 7,000 people are released from incarceration. This is prisons and jails, and they're returned to the Orleans area every year. Of the people that are released, more than 70% of them have some sort of a chronic condition. And greater than 90%, and in our region, nearing almost 100%, patients are uninsured at the time of release. As the laws are changing and policies are changing in terms of particularly the drug laws, we're seeing more and more people getting released out of incarceration. Many of the people who are being released are older. They went in maybe when they were young, developed some chronic conditions while incarcerated, and then are released now with medical conditions that they maybe didn't have before. So I told you guys a little bit about how the idea was born from our side of, starting a clinic for formerly incarcerated through seeing most of them at the hospital. And so the first thing that we did was kind of go out into the community and spoke with Norris Henderson, who's the executive director of a local organization called VOTE, which is Voice of the Experienced. And VOTE's been working with formerly incarcerated populations for many, many, many years, advocating for particularly voting rights. And so we went to Norris and said, we're thinking about starting this clinic. Do you also see that there's a need for this clinic? And absolutely there was a need. We heard stories about people being released, unable to get their insurance, and able to get their medications. And keep in mind, this is post-Katrina, so prior to Katrina, we had a centralized healthcare system. So people went to Charity Hospital, whether it was for emergency services, hospitalization, or primary care. Post-Katrina, all of that changed, and we started to make more medical homes, and we started to get clinics out into the communities. And so when people were released, they didn't actually know where to go because Charity Hospital no longer existed. And so people ended up, again, in emergency rooms and such.
All right, so now I'm going to talk a little bit about some of the work we did to get input into designing our services. And I'll just say, because Anjali told a little bit about her story of how she got involved, I got really excited and passionate about this issue. Several years ago, I had a very dear friend who was incarcerated for a very long time. And when he got out, he was very ill. He was literally on his deathbed. And he went initially to Interim Louisiana Hospital, which was the replacement for Charity, and he also knew Norris Henderson, who Anjali just mentioned. And Norris and I met literally shaking hands over the deathbed of my friend, who then later came home and did hospice at my house. So just say this to let you all know, it's a very personal issue for me, very near and dear to my heart, because I've seen what happens when folks don't get the care that they need inside. But as we were designing our services, we wanted to make sure that they were really sensitive and responsive to the needs of formerly incarcerated people. So of course we knew that there was no one better to ask than people who were directly affected themselves. So we partnered with our friends at VOTE to identify formerly incarcerated people in New Orleans. And then we did in-person audio recorded interviews with them. It was one of our medical students that did the interviews. His name is William Vale. He just graduated recently. And we just basically sat down with folks and asked them about their experiences with healthcare before they were incarcerated, while they were incarcerated, and then what their transitional care experiences were like as well. And then we did coding of the transcripts. So William and I each separately coded the transcripts and then merged our results to make sure that we were in agreement on the major themes. So we ended up approaching 29 people to participate, and 24 men agreed. They were all African-American men. And I will say we weren't intentionally excluding women. It just happened to be that those are the folks that were most readily available. Most of VOTE's members at that time were men, and we are now doing interviews with women to make sure that their needs are met too, but we did start with men. So among the folks that we interviewed, their mean length of incarceration was about 18 years. So these are folks who've been locked up for a very long time. And then on average, they had been out for around 7 or 8 months. So we learned some really interesting things in our interviews that were really quite eye-opening for us. So one of those was we learned that there were a lot of barriers to accessing care, even within the prison system where care, at least in theory, should be readily accessible. One of the issues that folks brought up was the EMT system, which is basically where an emergency medical technician will do an initial evaluation and then decide whether the person who's incarcerated should be referred for further care or not. So one of the participants in the interview said, you see the EMT instead of the physician. The EMT is trying to keep you from seeing a physician and figure out what you got and give you what you need. We also were surprised to find out that cost was a significant barrier to care in prison. One person said, that's why I stopped making those sick calls and having money taken from you. Sometimes I didn't have any money, and they automatically put a thing on your account, so when you do get money, they take it. So basically, in order for a person to see a primary care doctor, if they're not just going in for a regular physical, it costs $3, which doesn't sound like much to most of us, was actually incredibly expensive because most of the folks who are at Angola and some of the larger prisons in Louisiana are earning very, very low wages. And in fact, at Angola, the wage for folks who are working in the fields, I'm curious, does anyone know what it is? 2 cents an hour, yeah. So you can imagine it takes quite a while for folks to earn enough money to even see a doctor. Once folks did access care, we heard about several problems that they had. One was a lack of preventive care, and in particular for cancer screening. So one person said, I think I submitted my name in 2006 for colonoscopy or somewhere around there. I didn't get it done until 2014. And keep in mind, that's also someone who's asking for this type of screening. Many people don't know that they can ask for it. They said that providers often don't trust inmates, and basically that the inmates are pretending to be sick, or that's the perception of providers. So one interviewee said, everybody thinks like you fake like you're hurting. Why would anybody want to fake like they're hurting? Nobody's going to take care of you anyway. There were also many stories of interrupted or delayed treatment. One person said, well, I think as far as the institution, there was always an excuse. You couldn't receive this because of these funds or those funds. We need you working. So in other words, the perception was that the prisons would rather have people out doing their jobs, working in the fields, things like that, rather than getting the medical care that they needed. Another issue that came up frequently in our interviews was challenges with care coordination with outside hospitals. One person said, University Hospital called back and told the physicians at the prison that they wanted to keep me, but they said no, reschedule. But they had a mix-up because they thought I had the surgery and I went back to prison, but I never had the surgery. They sent me back and I'm constantly in pain. So this was someone who was talking about how they should have had knee surgery and never got it. In terms of the experience with transitional care, there were several different issues that came up. One was related to medication. So among the 20 people who reported being on some kind of medication, only 14 of those were given a prescription when they left so that they could go get a refill for their medication. And then most of them were given some amount of medication to take with them, but it ranged widely. Some people got none at all, and some people got up to 60 days. So there wasn't a standardized procedure across the various prisons. Another huge issue was that the prescriptions were not valid. So it turns out that many of the providers who are working in prisons do not have valid medical licenses for a number of reasons. So many people, when they would get their prescription signed by the provider inside, would go to fill it and find that it wasn't valid. And so one participant said, a lot of doctors that are in there, their licenses are suspended. So when their names are on certain scripts and when you return to society, they're not being acknowledged. Another issue that came up was that several folks said it was difficult to access their medical records after they were released. So one person said, when I asked for them, she said they didn't have nothing on me. They didn't have my medical records or anything. And I've been to the hospital and the medical several times in 23 years. We also asked folks about what they suggested for creating services on the outside or to support their transition back into society. So several people said specifically, please create a transitional care clinic. One quote that was reflective of that was, I think they should have something set up in the system already where they could call them and transfer you. Instead of telling you, you might could go here and you might could get medical care. If a clinic is set up for that, then there's no problem. There was also a desire for social work and case management. And one person said, a person that's been in jail for 20 or 30 years, returning to that newfound reality, society, responsibility, obligation, you need to be debriefed. They need social work. And several people suggested that we needed to collaborate directly with the Department of Corrections. And one quote that illustrated that was, I think you need a liaison with the Secretary of the DOC. That gives you access to the information of those who are newly released prisoners that are coming to work release and society that need medical treatment or need outpatient care or they need inpatient care once they get out. So those are some of the major themes that we found, and I'm going to pass it back to Dr. Niyogi, and she's going to tell you a little bit more about how we developed the clinic.
So we finally started the Transitions Care Clinic. It's called the FIT, so the Formerly Incarcerated Transitions Clinic, in May of 2015. It's the only transitional care clinic in Louisiana, and as far as we know, unless new ones have come up, it's the only one in the southeast region. The way that we selected where we were going to house the clinic, if you remember, greater than 90% and approaching 100% of the people coming out are uninsured. And so we knew that we needed to be in a facility that was going to be able to care for the uninsured population. So we selected a federally qualified health center, which is under a mandate from the federal government to take care of all people on a sliding scale basis, regardless of their ability to pay. The FQHC that we selected was at Ruth Fertel, which is on the corner of Broad and Orleans. And we selected that site because Tulane already has a pre-existing partnership with that clinic. And so medical residents from Tulane do rotations there. And so it just seemed like a natural fit. We started off and we're still at 1/2 day a week. And basically what that means is we can see patients Monday through Friday, but the 1/2 day a week that we are available for the FIT clinic is when we have all of our services, wraparound services, everything that we can offer sort of lumped together at that time. We can make it work at any other time, but it's just easiest to have a concentrated space. The other thing about the 1/2 day clinic is that they're incorporated into a walk-in schedule. And so basically that means that they're incorporated with all of the other patients. And this was intentionally done to mitigate any stigma that might be associated with it. So you didn't want to have a clinic that was formerly incarcerated on this day and everyone walking in was identified as being formerly incarcerated. And then, like I said, because it's an FQHC, we have a sliding scale payment. So what we offer at the clinic, we have primary and preventive care services, so just what anybody would get when they went to go see their PCP. We offer transgender hormone therapy, and we have we've partnered up with a couple of different organizations in the city. So we do behavioral health through a partner called Positive Living Treatment Center, and they help us with not only seeing our patients who might require mental health services, but also help lead peer support groups. So we have a bi-monthly peer support group for people who are just coming out. We've also partnered with the LSU Dental School, and so we offer basic dental services. And then one of the unique things that I think we offer at our clinic is this individualized case management. And it's actually run by medical students. And so medical students team up and are assigned sort of these patients when they come into the clinic, and they meet the patients on their first visit into the clinic. And each of these students has, I don't know if I actually have a slide about that, yeah. So each of these students has a Google phone, and they get a Google phone number that the patients then have access to. And the students are really responsible for making sure that all of those things happen. So if you can imagine, if you've been incarcerated for 20, 30 years and you're now coming back to society and you're responsible for not just getting a job and housing and all of those things, but also how do I take care of my medical needs? It's complicated enough for me, and I work in the system. And so the students really are there to help navigate that system. So do you know where to go to get your prescriptions? Can you afford them? Do you have transportation for your next appointment? Do you know when your next appointment is? So they do all of those things from a medical standpoint. They also work with our partners in the community to make sure, so if somebody comes out and says, I'm really excited about getting furthering my education. They'll work with our community partners who may be working on education for formerly incarcerated, and so they sort of link people up with the additional needs that they may have. One of the big things that they also do, so we have insurance enrollers at the clinic, and the medical students work with the insurance enrollers and the patients to make sure that they not only have their application submitted, but I don't know if anyone's applied for insurance and then you have that waiting period, you know, do I have other paperwork to fill out? Did I get accepted? Do I know what my card number is? And so they help to do all of that follow-up stuff to make sure that nothing gets dropped. So just kind of like what the interviewees had said, one of the things that was really important when we were developing the FIT clinic was to have a relationship with the Department of Corrections. We wanted to target, there's some studies that have shown that people who are within the first 2 weeks of release have a 12 times increased risk of mortality. And that's for a variety of reasons. And so we really wanted to make sure that we targeted people as they were coming out of incarceration so that they weren't sort of left on their own before things escalated. And so we spoke with the medical director and kind of got an idea of how many people are being released, where they're coming to, and we learned that 50% of people are coming back to the Orleans Jefferson Parish area. And then just some basic demographics. Who are these people? How old are they? What kind of medical conditions do they have? And we learned that greater than 70% of them had some sort of a chronic medical condition. Many of them are over 50 years of age, and if you remember from this quotes, a lot of people haven't had their cancer screenings or preventive screenings. So following that initial phone conversation, we then went to the headquarters in Baton Rouge and met with both the medical director and then the assistant secretary of corrections, and sort of developed a protocol for release in partnership with each other. We decided at that meeting that we were going to target Hunt Correctional Facility, and Hunt was selected because it's one of the correctional institutions that has the highest number of patients with medical needs. But as we started the clinic, we quickly realized that many of the patients who had heard about us and were coming from from many of these other large state institutions, and so we expanded to all of the state institutions, all the state prisons. So many of you have probably worked with the government. It's one thing to go and have a conversation and to sit down and to develop a protocol and say this is what we want to happen, and then you sit and you wait and you wait. So we decided that we were going to push the fast forward button on this, and we actually went to the prisons. We made appointments to meet with the medical directors of 4 large state prisons. So we went to Angola, to Dixon, to Hunt, and to LCIW, which is the Women's Correctional Facility. And we met with their medical directors and then also the directors of nursing. So when people have medical needs in the prisons, it's really the directors of nursing who are responsible for their care, and they're the ones who are assisting with the transition of once they're being released. And so those were the people that we really needed to speak with. And so we sat down, we reviewed the protocols with them, we kind of gave them how to contact us, what we needed them to do, what kinds of information we needed, and what kinds of information, or how would it be easiest for them to transition to us. Additionally, so that's from the medical standpoint. We worked with the nursing administrators and us, but what we really needed to do was to get to the people who were incarcerated, the patients who we were actually going to be seeing. And we wanted to let them know about the services that we offered. And so we thought the best way to do that was through people that they already trusted. And so we went back again to Norris Henderson, who's had a long, long history of working with people at Angola. And he, along with William Bale, who's our medical student, and myself, made a video about the FIT clinic, and to have that video aired in the prisons on their closed TV. Additionally, we do some in-reach now. We've been to a couple of job fairs in the prisons, and our next step is we're going to start offering some health education sessions in the prisons. And so that way people will know, they'll trust us, and they'll know that we're available and that they can come to us. So this data is tad bit old, but what we've had for our patient demographics, most of the people who come to us, 80% of them are men and 20% are women. The average age is 48 years. And the most common diagnoses that we've seen are hypertension, anxiety and depression, diabetes, hepatitis C, stroke, and substance abuse. I want to make one little caveat. So the things that already existed for people who were getting released in terms of medical services, if anyone has a severe, significant mental illness, they're already linked into Metropolitan Health. And so before they're released, they have follow-up appointments with them. If someone has HIV, they're already linked into the HOP clinic in New Orleans, and so that's already been established. And anyone who has end-stage renal disease that requires dialysis, they're already linked in. And so that's why you don't see those numbers here, but keep in mind that those numbers would be pretty high. All right. So, like I said, the DOC, now where we're at with the DOC is that whenever someone is getting released, ideally we're trying to have them make a date and time for an appointment with us prior to release. What we found is that that's not always possible because release dates are movable. So someone may think that they're getting out on January 23rd, but there's lots of things that have to come into play before they're actually released. So is their housing set up? Did they get good time? Did they have good time taken away from them? There's all kinds of things that really actually dictate when someone gets released. And so we were having inconsistencies between release dates and the appointment dates. And so now what we've done is just they're given information in their release packets about the FIT clinic. They're told how to contact us. And we're working on creating summaries from the prisons so that we can get that information. Medical records in prisons are handwritten charts. They're handwritten charts that are sort of scattered within the outpatient department, the inpatient department. So getting medical records to us is sometimes difficult. The person who with the quote was correct, that sometimes they say, we have nothing on this person. And you know that's not true because they've been in for 30 years and they have significant medical conditions and they've been hospitalized. So we're working on trying to formalize a process of getting medical records. DOC is working on trying to get an electronic health record so that we can have access to all of their records, but we're not there yet. So in addition to DOC, we get other additional referrals from our community partners. So VOTE is one of them, for 72 plus, which is housing for people who are coming out of incarceration, women with a vision. A lot of it actually comes from word of mouth, and many of our phone calls come from family members. So family members tend to know when their loved ones are getting released prior to even maybe DOC, or certainly before we do. And so they'll call and say, you know, my son's coming out in 3 days. Can I have an appointment made for him? We started with the state prison system because patients are in for much longer. They're usually older. They have known chronic health needs. And so we wanted to make sure that we were targeting that population before we sort of expanded out. We have gone to OPP. We've spoken to people at OPP and to the sheriff's office and let them know that we are around. OPP still doesn't have a medical director, and so the medical system there is in flux at best. But we're working on, you know, making sure that we're able to target those people as well. So some of the challenges and things that we learned after we started the clinic. So one of them, like I said, was the uncertain release date. And it's always important when you're working in a clinic to make sure that you can balance, you know, no-show rates with people who are actually coming into clinic, because if there's a no-show, they're taking up someone else's spot. And so we had to sort of recreate our protocol and how we were going to get those people. One of the other things that we learned was that a lot of people are being released on work release. And work release is essentially the same as still being incarcerated. So your time is incredibly, incredibly strict. So if you come to the clinic and your appointment's for 3, you need to be seen for 3 and you need to be out by whatever time it is. And so, you know, you don't have the luxury of saying, oh, you know, calling your job and saying, I was at the doctor's office, and we all know doctor's offices run late, but if you're on work release, you're not allowed to do that. And so patients were leaving. They would come for their 3 o'clock appointment, and if they weren't seen exactly at 3, they would leave because they were so worried about the repercussions of not going back to sign in. We talked about the medical records. It's been, once a patient's released, getting those medical records is really, really difficult. So we're working on trying to see how we can get medical records before they're released. And we're making some success with it. The other thing is that, like I said, the clinic is at the Ruth Fertel Clinic, and it's open to everybody. If we really want to offer the full range of services, we're asking people to sort of identify as being formerly incarcerated through a different, number of ways that we ask those questions, rather than were you incarcerated, and that is one of the questions that some people can be asked. But that's been one of the problems is, we're encouraging people to, in whatever way they feel comfortable, to identify themselves as needing the services of the FIT clinic. Doesn't matter if they don't. Once they come in to see us in clinic and we sort of recognize that they would benefit from the services, we sort of transition them over and they still get services of the FIT clinic. But in order to track our numbers, in order to make sure that we're targeting all of that population, we're asking them to identify. And so we're still trying to come up with language that might help us identify who those patients are a little bit better. Some of the things that have worked, so if a person has a certain release date, which amazingly happens at the women's prison, most of the people in the women's prison get out on the day they're supposed to get out. We get an email, we get a phone call that says this person's going to come out. We give them a date and a time. The patient knows the date and the time before they come. LCIW faxes over the medical, their medical records, and we have everything together with us. Additionally, so the nursing directors of the prison and transition specialists, we oftentimes can call them or they call us and let us know that someone's coming out. We've talked with the call center, the front desk. We've changed phone numbers. We've kind of instituted new lines that are directly for FIT clinic patients. And so instead of, one of the things we're trying is, instead of patients having to self-identify as FIT patients, we're giving them a phone number that would be a direct link that would identify, that phone ringing would identify you as a FIT patient. And so that we don't have to stigmatize or require anybody to sort of, tell us that they're formerly incarcerated. So what are we still waiting on? We have no money. So all of us that work at the FIT clinic, including myself, is doing this on a volunteer basis. So if anyone knows anyone that has money, wants to give money, we'll happily take it. And then, as Ashley had mentioned before, the interviews that we had done were primarily with men. We do see women in the FIT clinic as well, but we really want to make sure that we are able to provide the services that women feel that they need. And so the next step is going to be to do these interviews, which we've started interviews with women that are formerly incarcerated. We have some more research things that we're working on to make sure that the services that we think we're actually providing, that patients find them useful and beneficial, and then also how can we improve and change, and what next we need to do. We're working still to strengthen our ties with the DOC. We're also working with the DOC. We were working with DOC with Medicaid expansion in hopes of getting patients signed up for Medicaid prior to release. I say we were because we'll see what happens with Medicaid expansion and ACA. But that's the next step that we're hoping for, is to get people Medicaid before they're released. And then Ashley and I are co-PIs. Ashley's really the lead on a PCORI grant that we have, which is a patient-centered outcomes research initiative, looking to see, it's a comparative model, looking to see what are some better ways that we can offer the things that we're offering, or looking to see some evidence-based models for the things that we're doing. And then we're also hoping to work with other such clinics throughout the Southeast and throughout the country. And that's it. So the question was whether, when we did the interviews with formerly incarcerated, was there a large difference between young patients and older ones?
That's a good question. So honestly, we didn't interview a lot of very young people just because so many of them had been locked up for such a long amount of time. If we were to think about differences, I imagine access to care issues are probably pretty similar across the various institutions. As far as for the health outcomes that people are experiencing, I imagine those are a bit different, and that the older people are more likely to have chronic conditions. I don't know, does that answer your question? Sure. So, I mean, so the point that the audience member is making is that some of our folks were incarcerated for about 18 years, but they may have gone in as juveniles, and that is definitely the case. So some people are coming out in their late 30s or early 40s. I don't know that we had enough of a sample size to really look at the differences between those folks and the people who are a little older, just since it was so small. But it's a good question.
Yeah, so absolutely. There's something called a post-incarceration syndrome, which is similar to PTSD for war vets, and is responsible for a lot of these barriers. And so the idea of kind of overcoming the trauma that they have felt and then coming into society and sort of being thrown in, and how do you actually successfully reintegrate, and particularly when you're coming from a place where you haven't had a lot of agency and you haven't been able to really do the things that you needed to do to take care of yourself. And so that's been responsible for a lot of the barriers. In addition to that, yet they're coming from places where, you know, all of those interviews are sort of, no one's cared for me, no one's taken the time to do all this stuff, and so there's been a lot of distrust. What I will say is that we've also heard from a lot of patients about how they do feel heard for the first time. And so coming into the clinic, particularly having, you know, an individual case manager and really having someone that's there with them walking through these sort of steps and these barriers, I think has helped a lot. In terms of, I don't know if it's helped in terms of health outcomes, but in terms of gaining trust. I think having that one person that's there over and over, and then also being connected with community organizations that have been working with formerly incarcerated has also helped gain trust.
Just one other thing that I think is interesting to add, I didn't include it in the interest of time, but one of the things that we found in our interviews was that almost every single person that we spoke with talked about things that they had done while they were incarcerated to try to preserve their health. So a lot of folks talked about using their money to buy their own food, making sure to work out. They talked about meditation and prayer and all kinds of things that they did to sort of manage their mental health. And I think that's really key too, to remember when we're thinking about serving this population that has been traumatized and just been through, frankly, absolute hell, is that they are resilient, really, really creative people who've done a lot to preserve their own health. And as such, they're very interested in sort of promoting their own health in a way I think that many other populations aren't.
So the question was, what percentage of our patients have been reincarcerated? I don't think any of the ones that we have at the FIT clinic right now, but we're very young, so the FIT clinic's only a little over a year old. None of our patients have been reincarcerated. We have one that we're working with their parole officer right now to keep them out of going back to jail. In terms of were they to be reincarcerated, could we get medical records back to where they are? Potentially. So it depends on if they end up at a jail, at a local jail, or at a prison. If they end up back at the prisons, we have good relationships with the people that are there. A lot of health providers in the jails and prisons are fluctuating, and so there are many times contract physicians and contract nurse practitioners, so it's harder to get that information. But I think that I think that there should be a protocol. I think it's a good question to have a protocol to be able to get information back again. It's a great question. I'm going to actually let Ashley answer that question. The question was who the case managers are. And the case managers are medical students. They're mostly fourth-year medical students. We chose them to be fourth year because they've done their clinical rotations, and so they're a little bit more familiar with the constraints and barriers of the health system in our population. And in order to train them, and this is where I'm going to give it to Ashley, they get training through a variety of different sources.
Sure. Yeah, so we want to make sure that they're prepared to work with our patients. So we give them training in a few basic skills that are really important in case management generally. So we teach them how to do just sort of basic case management, and then also how to do things like motivational interviewing if they're working specifically with patients that are trying to change their health behaviors. They get some training in working with patients and how to set goals and follow up with them. So we try to leave them in good shape to have some of those skills. And then we also do sort of a cultural competency type training, and I hate that word, but sort of cultural humility training that's important for working with formerly incarcerated folks. So we have some of our partners from VOTE come in and talk about a lot of the common issues that people face during incarceration that they might otherwise not be aware of. And then I also share with them a little bit about my experiences in visiting prisons for a very long time. So, hopefully they're well prepared. And a lot of the training that we offer is based on training for community health workers that's been developed and around for a long time.
So yes, the question was, is there health education in the prisons? And the answer to that really depends on the prison. So there's tons and tons and tons of classes in prisons. They have classes for parenting, they have classes for substance abuse, they have all kinds of different classes. There's no standardization of how those classes are taught, who teaches them. Sometimes you might just get one person who decides they want to come in and do a class on something, and that would be all there is. We are actually in the process, we've designed a curriculum based on sort of the common conditions that we see. We've designed a curriculum of 6 topics right now to go and teach in the prisons. One of them is health system. So what does insurance mean? I think I need that class. What's a co-insurance and what's a copay and what's a referral and how do all of those things work? That, and then also some of the chronic conditions. So I think the first question was, what do we do with the scripts when we recognize? Yeah, so if anyone goes and tries to fill the script that's not valid, we're trying to get the word out that they can come to us and we'll refill that prescription. What we're hoping to do is to get them to us even before they ever run out of medications. Like Ashley said, there's different amounts that they get in hand. Oftentimes they'll get at least a 4-day supply, sometimes a week supply, so we're trying to get them to us before they run out of medications and rewrite a script. And then, we get a lot of people. So we're trying to target patients as they're coming out early, but a lot of our patients, particularly early on, were people who'd been out for months to years. And anyone who really thinks that they could benefit from our services, we're happy to see them. The reason that we had targeted that population, it's a transitional clinic, and so we're hoping to get them embedded with a primary care doctor as their sort of long-term, as the long-term goal of it. And a lot of people who've been out for a while have seen providers or are already embedded with primary care providers. But like I said, we offer other services in a way that's, I think considers some of the trauma that they may have felt before. Yep, both great questions. So the first question was prioritizing health when you have so many other constraints. And so a couple of things we do. We work with community organizations that do housing and employment and job training and mentorship. One of the problems that we run into in New Orleans is that there's just not a lot of organizations. I mean, it's really hard to get housing in general. There was a recent victory from our VOTE partners with Cano and HUD where you cannot discriminate on a history of being formerly incarcerated anymore, and so we're hoping that's going to open up some housing units. But we work with community partners. So we ourselves don't offer any of those, but we work with community partners and refer them to those sources. The other thing that we're doing is the peer support group. And part of the peer support group is we're working with people who have been successfully out for many years. So a lot of these people have come in and out of incarceration, but have now been out for a period of time. And so we're developing a curriculum with them to say what has helped you be successful. And so, including parenting skills, including, behavioral change, including mentorship and job training and things like that. The other question is about Medicaid. And so we are working with DHH and DOC to try to get Medicaid enrollment. The problem has been, so each state has a different protocol for Medicaid. And in Louisiana, the barrier was that in order to get Medicaid enrollment, you had to have a house and an income, and so the requirements that we have weren't applicable to people while they were incarcerated. And so there's a process in which that they're working with with Medicaid office to change some of those requirements, but we aren't there yet. The goal was to have this January, we were hoping to have to open it up for prisoners to get Medicaid upon release, but it's been pushed back, but hopefully this summer.
Need to be recorded, but the question was, how can public health students get involved in the FIT clinic at this point? I think we're actually pretty saturated with medical students at this point who are doing the case management, which is great, and they're wonderful, and we love them. As far as public health students, honestly, the thing that we could probably use the most help with right now is fundraising. So if anyone is interested in working with us and has good grant writing skills or is willing to learn, we would love to have you on board, and I'll happily work with you to support you in helping us.
And also, if anyone has studied health what's it called? Health literacy and health education. So as we go into the prisons to do some of the health education sessions, it would be great to partner with students and, who have experience doing some of this community education work.